Welcome everyone to the latest installment of the Fitzhugh Mullen Institute of Health Workforce Equity's webinar series on emergency health workforce policies to address COVID-19. This webinar, which is co-sponsored by the Beyond Flexner Alliance, will focus on ensuring access to behavioral health. Now, as this COVID pandemic unfolds, ensuring access to care while both protecting patients, healthcare workers, and trainees is a national priority. My name is Isabel Chen, and I will be the moderator for this session. I'm a family medicine physician in Los Angeles, and I work in a mix of primary care and addiction medicine. I'm also a board member and communications co-director for the Beyond Flexner Alliance. The Alliance is a national movement focused on health equity and health equity training for all healthcare professionals so that they can be agents of more equitable change and a more equitable healthcare system. We have upcoming conferences. Our next will be in Phoenix in 2021, and we have a very live and active online community of educators and trainees sharing innovative ideas to achieve our shared goals and social mission. I have the wonderful pleasure today of introducing our two speakers and also moderating this conversation. First, we have Miss Amy Roeschlein, who is a skilled licensed clinician. She has led healthcare teams and behavioral health programs for the past 20 years and is currently a consultant at the National Council of Behavioral Health with her portfolio in resilience-oriented trauma-informed care and integrated health. She completed her doctorate at USC with a focus on innovation and creating large-scale social change through transdisciplinary training of mental health providers. Amelia enjoys developing and implementing programs in integrated team-based healthcare settings. She has published research and has expertise on the subject of harm reduction and in reentry in incarcerated populations, interpersonal violence, personality disorders, co-occurring disorders, trauma-informed care, compassion cultivation, adaptive leadership, and team-based healthcare, to name just a few areas of her expertise. It is a pleasure to welcome you to this panel. I'd also like to introduce our second speaker, Dr. Joe Parks. Dr. Parks currently serves as the Vice President, Practice Improvement, and Medical Director for the National Council of Behavioral Health. He is a distinguished research professor of science at the Missouri Institute of Mental Health with the University of Missouri, St. Louis. Dr. Parks is the National Behavioral Health Rep at Large for the Joint Commission as well. He currently practices outpatient psychiatry at the Family Health Center, which is a federally funded community health center established to expand services to uninsured and underinsured patients in Columbia, Missouri. So beginning our conversation today, I'd like to direct our first question to Dr. Parks. Dr. Parks, can you provide a brief overview of some of the key federal and state policies that have been enacted to facilitate greater access to behavioral health services during this pandemic?
You know, thank you, Isabel, and thanks for the opportunity to be on here, because there's been so much change going on in just the last 60 days. It really bears talking about. There are policies that we've been wishing would change for years that suddenly are completely different. And the changes are coming rapidly from many different quarters, from both state level, from federal level, from individual payers. It's all good, but it's kind of dizzying. There's been a tremendous loosening of the restrictions on the different platforms and modalities that can be used. You can use FaceTime, you can use Skype. In some states, they're allowing providers to provide services across state lines, and CMS is waiving all federal restrictions against payment across state lines. But CMS can't waive the state's regulatory authority over scope of practice. So that's going to vary state by state, and it's going to change week by week as states struggle to better respond to the epidemic. There's waiving for the patient cost share of services. Co-pays are often being waived. And there's a lot more services that are available by telemedicine than were ever before in behavioral health or in general medicine. And perhaps the biggest change is many services are available telephonically. Before the services that were available remote, you all had to have video. Of course, many of our patients don't have video capability either with connectivity or with the amount of data time in their accounts to be able to afford it. So the telephonic care is really a huge opening of access, especially in rural areas, but also for all of us in urban areas that are distancing and quarantining and staying in. It's been striking.
Thank you for that response, Dr. Parks. Moving on, a follow-up question to that is whether or not you have encountered any challenges, you or the council have encountered challenges on implementing new telehealth options. And can you speak to perhaps whether or not patients have access to said technology given the policy changes? Dr. Parks?
As I mentioned, people in rural areas are greatly benefited by the telephone availability. However, many of them on the video side either don't have connectivity or don't have the amount of time to make use of it. And some of them are challenged just being able to work the applications. I do clinic on a regular basis, and not all my patients are familiar with using Zoom or using Skype, which is why the availability of telephone has been a real blessing. The other challenge we've had here, Isabel, is our agencies didn't have all the equipment. Many of our workers did not have laptops. Many of them were not set up and connected to go mobile at home themselves also. And there's been a real struggle at many behavioral health agencies to get the treating side the laptops and remote capabilities. They've responded rapidly, but it's been a real scramble. I think another area where it needs more support to work well is people need training. How do I do an interview by telephone when I'm used to doing it in person? And how do I do an interview by video? And we've been getting the most questions from, I do group therapy. How can I get a group going remotely? How do I get that Zoom room with multiple people to work out? And how do I handle my therapeutic dialogue with people? Luckily, there is more training out available. People should check out our landing page at the National Council. We have a number of resources, and there are some financial relief coming down the pipe. We have a summary of what's available through the CARES Act at the web link that you see on our slide. And it was just recently announced this week that the FCC is providing funding for some of the telehealth IT costs. This will be an application process. It'll take some time to get it out to providers so they can implement it. But people should go to that link and see how they can get their application in as soon as they can.
Thank you, Dr. Parks. In your introductory slide, I was wondering if you could speak a little bit more to the actual waivers that are being implemented at this time, and also if you might be able to speak to some of the more vulnerable populations at the intersection of mental health, specifically those with substance use disorders.
Sure. One of the big changes is that there's been a waiver of enforcement of HIPAA, whether that's by platform or with the necessity for the degree of written consent. You can get consent verbally over the phone, you can get consent verbally by video, and we can use many platforms we couldn't before under HIPAA. Those are all explicit changes. There's been a lot of loosening up in the opiate and the general substance abuse treatment side. SAMHSA has exempted the opiate treatment programs from the requirement that they have to do an in-person physical examination of any new patient who will be treated with buprenorphine. You do still need a physical examination to be treated with methadone, at least one at the beginning. They're allowing services to be done by video and also done by telephone. And the broadest change is opiate treatment programs, if they deem a patient stable, can give 28 days of take-home doses and up to 14 days of take-home doses for people that are less stable, but they think they can safely manage and handle it with enhanced video or telephone contacts. And a lot of these treatment programs are small businesses. They have fewer than 50 the employees, many fewer than 100 employees, which makes them eligible for the Small Business Administration COVID Economic Injury Disaster Loans, or eligible for SAMHSA emergency grants to address mental illness and substance use disorder during COVID-19. And people are spending a lot of administrative time just getting those resources. But the change in regulation has been striking on the confidentiality side, as well as on the reimbursement side. A lot of this has been done through the 1135 waivers. These are Medicaid waivers that allow your Medicaid program to make changes in an emergency. So these changes done under the waiver are good for the duration of the emergency. And there's real debate starting up of how much of this we're going to want to keep in place after the emergency. There are many things that we've done as an emergency move that have brought in people and kept them connected that we would not have been able to engage and keep in service absent the epidemic. And I think we're going to see some real policy dialogues and arguments as this winds down and the epidemic is not as urgent a problem. There's many things that we should be keeping here.
That's great. Thank you, Dr. Parks. As a provider of addiction medicine, your points that you raised as they relate to policy changes for substance use disorders and the care for patients is really very important during this pandemic, as is also the impact that a lot of us as providers and small business owners and healthcare systems are experiencing in the wake of significantly reduced patient volumes. And access as well. So I appreciate your description and mention of all of the variety of relief funds that are available to providers, clinics, and health systems at this time. Dr. Parks, would you? Sure, go ahead.
Well, I'd like to say a little about the scale of the financial impact on providers, because the regulations have opened up faster than the payment methodologies have changed. So although there's an opportunity to make payments in ways they couldn't, payers are not always taking advantage of that rapidly. And many providers are seeing significant drops in revenue, even when they're able to transition and do services remotely by video and telephone. They're finding they're not getting paid, or they were able to start delivering the services at the beginning of the month, but the payers are not willing to make payment retroactive to the beginning when they weren't able to reprogram their payment systems till the end of the month. So there you lose a whole month of payment just because the other party couldn't execute as fast as you could. In a recent survey we administered to over 600 behavioral health organizations nationally, we found that on average, the providers had to cancel, reschedule, or turn away about a quarter of the patients they usually saw due to the outbreak. 24% of them said they only had enough cash on hand to survive about 1 month with this reduced cash flow. And 75% said they didn't think they could make it more than 3 months. 45%, almost half, had already laid off some workers, either furloughed them temporarily or laid them off. So these are organizations that do not have large cash flows, and if the payers, whether that's state, federal, or commercial managed care companies, cannot act more quickly, there will not be providers available after the epidemic or during the second half of the epidemic. This is probably the most dire need this week at the moment, is for the payers to figure out how they can get the payments out for services that have been provided and can be provided, that they're just haven't programmed and into their payment systems rapidly enough.
Right, and this will demand of all of us significant flexibility and adaptability. And so thank you for explaining that, Dr. Parks. Now, what additional policies, in addition to already these pretty significant changes that you've already mentioned, what additional policies do you think are needed to address remaining access barriers, emergent access barriers?
Mm-hmm. Some of the biggest policy changes that have been unaddressed are due to the differences in areas of authority. So there are a wide range of differences across individual states, but people have moved suddenly. College students that were in one state have gone home to another state. They have existing treatment relationships but that's a change of scope of practice from the state the provider was in to the state the person was in. And this varies across multiple different state combinations, and it becomes almost impossible for individual providers to figure out which of the 8 different states their patients have gone off to now they can still serve them, even though they could do it by telephone or video. It's hard. It's been the states have not come together as a group to say we all are going to sign on this common waiver of licensure restriction that keeps you within a state. We'll recognize a license for any state as long as this is it. That would be very helpful. I think the other thing is not adapting payment rapidly enough. The biggest need is for interim payments to providers based on what they were expected to charge anyway. You know, most payers have an average budget and costs average out about the same all the time. So there was an expected spend, either in Medicaid and Medicare or in any managed care company, of how much behavioral health was going to cost during the month of March and the month of April. And those actual bills amounts are coming in radically lower because people aren't able to come to the office. And the policies have changed day by day. It'll be almost impossible to go back and rebuild them individually. What really needs to happen are an interim retainer payment. A retainer payment is when you pay a provider about what they would have been paid in previous months under the old conditions, just to keep them in business and to cover their costs of paying for services delivered in a different manner than meet your old billing requirements. People are getting good and adequate care. It's just not done in the same way that was required for billing before. So we end up with people getting some care, but providers not getting paid, which can only go on a month or two, or they won't be able to provide the care because they won't make payroll. And this is really going to be dependent on payers figuring out how to make a retainer payment, paying providers on average what they would have earned before the epidemic for that month. I think that needs to happen temporarily during the duration of the epidemic. It doesn't have to go on forever. But if that doesn't occur, there's going to be permanent loss of capacity and a marked decrease in the care people can get.
Right. So it sounds like it's absolutely important that we find policies to help keep providers and their businesses whole throughout this pandemic and during this period. I'd like to transition off of this concept of keeping providers whole and invite Amy Roeschlein to the conversation to speak a bit more about how providers and their own behavioral health needs are being addressed during this pandemic.
Let me do one last little reframe, Isabella. It's not a matter of keeping them whole. There's no doubt they're going to take losses. We're just trying to keep their doors open. You know, they're going to take a hit, but we don't want them to take such a big hit that they go down and they're not there to serve their communities and the people with illness.
Right, I appreciate that. So this question is for you, Ms. Roeschlein. In addition to ensuring patients have access to care, increasing attention is being placed on the behavioral health needs of providers during this current crisis. Can you talk a little bit about some of their needs that providers are encountering at this time?
Sure, and thank you again, Isabel, for having me here with you today. There are so many stressors that are out there today. We're all in different situations, whether we're at our jobs during this crisis trying to work or at home during this crisis trying to work. So those of you in particular that are working the front lines are not only experiencing new pressures, but are being viewed by the community as a whole in a different light than before. I think some of this is positive, but maybe even more of it is added stress. Looking through a trauma-informed lens, we have to recognize that there's specific needs for providers. So looking at compassion-focused research might help us understand further. Dr. Paul Gilbert proposed that we have 3 main types of emotion regulation systems. The drive system is a motivational system that also has roots in our evolution, in that it drives us towards the things that we want or we need, and it helps us focus and maintain our attention. The soothing system allows us to soothe ourselves and also to soothe others. It's linked with acceptance, kindness, warmth, encouragement, and support. It's why leaning into others is the most potent way to feel better in the moment. And then finally, the threat system helps alert us to potential threats and obstacles and helps to keep our lives moving in desired directions. Research shows us that we're biased towards processing threat-based information. We know that negative information captures our attention and our memory much more powerfully than positive information. So we're wired as a species towards anxiety and stress, but the good news is that we're also wired to handle it. I think it's important to recognize there's specific needs for providers depending on their developmental level. So for those of us that have been in the field a while, we need to overcome the culture of putting ourselves last, not taking days off, shame or worries regarding letting others down. Much like when flying, we need to be reminded to put on our masks first during times of crisis, to actually engage for maybe some of us the first time in the self-care and the stress management tools that we teach our patients. This is an opportunity for us to model vulnerability and humility for our trainees and students. The courage that it takes to be authentic during adversity has the potential to create a much more resilient workforce in the next generation of healers. And then for those who are newer to the field, these experiences will be the superpowers that are going to help equip them for managing this in the years ahead.
Thank you for those insights in this time of immense trauma, intersecting with the significant burnout epidemic that providers also face. I think your framework here and description of the regulation systems is incredibly helpful. Amy, do you mind speaking a bit about how providers are actually accessing mental health care at this time, and perhaps what innovative approaches might exist to help them immediately?
Absolutely. We're hearing about a ton of innovative approaches right now from providers actually leaning into each other to using telehealth resources that match their work schedules, as well as integrating brain-based soothing techniques and check-ins to all aspects of service delivery. I think one of the neat things is on the next slide. I wanted to share a self-care reminder card that Mental Health First Aid put out that could be added to providers' badges. So they actually have something in their hand that they can review when they need a few moments to ground themselves. The next slide actually shows a resiliency app that can track burnout and compassion fatigue and prompt providers to engage in strategies such as increasing their heart rate to relieve stress.
These are great on-demand tools that I think would be really helpful to be encouraged and implemented on a wide-scale level. Now, switching back to sort of the policies around behavioral health needs and support resources for providers, what policies or programs do you think, Amy, will be needed to address providers' mental health needs following this crisis? And what do you think health systems should be thinking about now in order to help providers through the next few coming months and potentially subsequent waves of this pandemic?
Yeah, that's a tough question, Isabel. On the next slide, I think that health systems are going to need to adapt and recognize the importance of compassion satisfaction and compassion fatigue, using wildly accepted models such as the professional quality of life elements theory and measurement for understanding the impact of trauma and the caregiver. Is going to be incredibly important. You can go ahead on to the next slide. This tool and similar tools can be used by all human service professionals to start to monitor their compassion fatigue, their burnout, and their compassion satisfaction scores. You can go ahead and advance the slide. I think we're going to start to see that creating a culture of compassion is going to involve connection and problem solving together. So health systems are going to be challenged with creating safe and nurturing environments, making sure that expectations are clear to everyone, providing affirmations, attending to the psychological, emotional, and social safety of their staff and clients. Through collaboration and mutuality, there's always true partnering and a leveling of power differences, which is, I think, what we're going to need to be able to move past and get through this together.
Thank you, Amy. Now, as we wrap up, I want to invite both Dr. Parks and Dr. Roeschlein back into this conversation and share a bit of thoughts about how we should be preparing for the future. How can we prepare our systems and also behavioral health resources, not only for providers, but more broadly, the general public following this pandemic?
Yeah, this is Joe, and I think it mostly requires that we be flexible and adaptable. We need to be willing to do things differently, and just because we did things a certain way in the past doesn't mean that's going to be useful or helpful in the future. This can both be stressful, but it also can be very enjoyable and a real opportunity for creativity. The question shouldn't be at this point really so much what is the legal way or the way that's appropriate with prior practice guidelines. It should be what does the person need and what can work and what is doable. And I think even as importantly, what is sustainable? What can I do in a way that I can keep on doing it? This epidemic is going to be a marathon. It's not a sprint. And you can't give every last bit you have every day, all day, and keep going for all the time we're going to have to do this in the future. So we're going to have that balance between being able to give to others, take care of them, give some extra effort, but also reserve something for ourselves, because if you don't take care of yourself, you're not going to be useful to anyone.
Absolutely. There's been a great amount of conversation around getting PPE to frontline providers, and in the same vein, what type of protection can providers and the general public sort of arm themselves with to ensure that we're all ready a few months from now?
You know,
Any thoughts,
the other
Dr. Roeschlein?
Oh, go ahead, Amy, and then I have another thought.
Sure. I think that what we're going to need to really focus on is a lot of what Joe spoke about, which is building in resilience approaches, ensuring that staff have proper tools and resources to do their jobs, much like the PPE that you were talking about, Isabel, and including trauma-informed supervision and ongoing resilience and compassion satisfactions trainings and skill development, I think are going to be really important.
I think we need to I think this offers us two opportunities. We, of course, worry about ourselves being traumatized and others being traumatized by the epidemic experience. But I think we need to remember that not all stress and discomfort leads to trauma. It often leads to resiliency and strength and new skills. The one thing that victims and heroes have in common is both have been wounded. And there are things about this epidemic that wound us, but we could end up heroes instead of victims. And part of that is taking care of ourselves, and part is being generous. Part of that is being generous with others. I think the other thing we need to do is stay realistic about our fears and how much time we spend on the epidemic. You know, it makes me think of how I talk with my patients about recovery. Recovery from any chronic illness, whether it's diabetes, cancer, schizophrenia, substance use disorder, is kind of this balance of whenever you have something you can do that would really help your illness, you need to drop everything and do it. But if you've done everything you can, you certainly don't want to keep doing things related to your illness just to be doing something about your illness. Because the whole point of taking care of your illness is to get on with life. So I think how this epidemic challenges us, especially as it goes on week after week and month after month, is how can we decide what is worth doing related to the epidemic? What will really make a difference? And when we're just doing additional things to be doing something symbolic, you know, how often do you need to clean something? Certainly we need to wipe things more, but we don't need to spend all day wiping things. And I think it challenges us to make that moment-to-moment decision, just like our patients' illnesses challenge them. So we don't become just about the epidemic, just like we don't want them to become just about their illness.
Right. Well, I thank you both so very much for your incredibly insightful comments and descriptions of the absolute importance of not only caring for ourselves, but also ensuring that there are policies and systems that are responsive and adaptive immediately during this crisis, for the months that follow, and ultimately just regrounding us in the importance of individual self-care and sort of the compassion and resilience that we can foster among our communities. So on that note, I'd like to thank all of our presenters. I'd like to thank the Fitzhugh-Mullen Institute for Health Workforce Equity, and also the Beyond Flexner Alliance for co-hosting this webinar. And I'd like to end with a quotation from Dr. Fitzhugh-Mullen that health workforce policy is increasingly a health equity battleground. Thank you again for both of your time.